Usually when we discuss diagnostics in medicine, there is a clear expectation of precision, like it feels binary. An orthopedic x-ray shows a jagged white line across the femur, and the fracture is undeniable.
Absolutely. It's visible, it is categorized, and it dictates a very specific mechanical response.
Right, but when you step into the world of the acute human abdomen, that comfort just entirely vanishes. The diagnostic landscape of the right lower quadrant is notoriously murky.
Murky is the perfect word for it. The clinical presentation is ambiguous, the physical exam can be highly subjective, and, well, imaging doesn't always hand you a definitive answer.
Yeah, you are basically operating in diagnostic muddy waters.
Exactly. It is an environment that demands both profound anatomical knowledge and, intense dynamic adaptability, which is precisely why this specific procedure requires absolute structural discipline.
And that discipline is exactly what we are dissecting today. Welcome to the Surgical Educator's Advanced Online Operative Surgery Masterclass. Allow the words in this deep dive to permeate into your mind. In this session, we are going to discuss the various operative steps in laparoscopic appendicectomy, along with excellent line diagrams as if going through an operative atlas.
Yeah.
Visualize the patient discussed in your mind's eye or run a mental movie of the various steps of the surgery to have an indelible impression. By doing so, you will experience an immersive and transformational learning experience and gain the much-needed confidence to do the surgery successfully. This will eventually result in achieving excellence in surgery. Thank you.
That really sets the tone, because our source material today is a phenomenal masterclass presentation designed by Dr. B. Selvaraj.
Right.
We're unpacking an operative atlas that breaks down laparoscopic appendicectomy step by step.
And, the goal here isn't just to memorize a sequence of actions.
No, not at all.
It is to deeply analyze the physics, the spatial geometry, and the anatomical rationale behind every single instrument movement. Okay, let's unpack this and jump straight into the setup. I am explicitly announcing the transition to our first slide, slide 1. We are looking at indications, anesthesia, position, and consent.
Let's look at those indications first.
Yeah, the slide lists acute appendicitis and subacute appendicitis as primary indications, which is standard, but then it explicitly lists diagnostic laparoscopy in doubtful cases.
Right, and that completely reframes the initial approach.
I mean, we aren't just going in to excise a known pathology at that point, right? The laparoscope is actively serving as our definitive diagnostic tool.
That distinction is critical for the operating surgeon's mindset. When the clinical picture is equivocal, perhaps you're dealing with a female patient where ovarian pathology or pelvic inflammatory disease must be ruled out.
Oh, wow. Yeah.
Or even just an atypical presentation of right iliac fossa pain. The procedure actually begins as an exploration. You are evaluating the terminal ileum, the adnexa, the gallbladder, and the entire peritoneal cavity.
So the camera is essentially investigating the muddy waters before any commitment to resection is made.
Precisely. And to conduct that investigation safely, well, the physical environment needs to be perfectly controlled.
Which brings us to the anesthesia and position section. The slide mandates general anesthesia with an endotracheal tube, or GAET.
Yes.
Obviously, airway protection is paramount, but for laparoscopy, we also require profound neuromuscular blockade, right?
Yeah, the neuromuscular blockade is entirely about managing the physics of the pneumoperitoneum. You are insufflating the abdominal cavity with carbon dioxide to a pressure typically between 12 and 15 millimeters of mercury.
Which creates that pneumatic dome.
Exactly, your entire working space.
Yeah.
If the abdominal wall musculature is not completely paralyzed, the intra-abdominal pressure will force the diaphragm cephalate.
Pushing it up.
Right, pushing it up, which compromises pulmonary compliance and increases airway pressures. You need absolute abdominal wall flaccidity to maximize the operative volume.
All while minimizing the respiratory and hemodynamic impact on the patient. So that sets up the internal space. But then the slide dictates the external physical orientation. It says supine with slight left tilt. Let's analyze the mechanics of that specific spatial adjustment.
This is where gravitational physics becomes an instrument in your surgical toolkit. The target is obviously in the right iliac fossa.
Right.
But the peritoneal cavity is highly dynamic. The greater omentum and loops of small bowel are incredibly mobile and will naturally pool into whatever space is available.
Just following gravity.
Yes. By applying a slight left lateral decubitus tilt to the operating table, and often coupling that with a slight Trendelenburg position.
Which is tilting the head down a bit.
Exactly. Head down. Gravity then acts to gently slide those mobile structures down and away from the right lower quadrant.
So you are effectively using gravity to retract the viscera before you ever introduce a physical grasper.
Exactly. It clears the field and exposes the cecum organically. It really reduces the need for traumatic manual handling of the bowel.
That is fascinating. Now let's look at the informed consent section of this first slide. The complication data points are very specific.
They are.
Post-op adhesions are listed at less than 1% and fecal fistula at less than 2%, but the intra-abdominal abscess rate sits at less than 8%.
Right.
That 8% figure feels highly significant compared to the others. What does that tell a surgeon about setting patient expectations?
Well, it is significant, and it reflects the inherent challenge of the pathology. An acute, gangrenous, or perforated appendicitis means you're operating in a grossly contaminated field.
Yeah, it's infected.
Exactly. Despite copious irrigation and meticulous technique, the risk of residual bacterial load pooling in the dependent areas, like the pelvis or the right pericolic gutter.
And forming an abscess.
Right, forming an abscess. It is a physiological reality. That 8% tells the surgeon that controlling the sorts is only part of the battle. Minimizing peritoneal contamination during extraction is just as vital.
And the slide also mentions injury to hollow viscous and vascular injury, hypercarbia, air embolism. But I want to push back on the final point under risks.
Okay, what's that?
The slide lists conversion to open method if dense adhesions. If you are an advanced masterclass surgeon, shouldn't you possess the technical proficiency to dissect through dense adhesions laparoscopically? Framing conversion as a risk almost makes it sound like a failure of surgical skill.
That is a very common trap for advancing surgeons to fall into, allowing your ego to override safety.
Right.
Dense adhesions distort the anatomy completely. The inflammatory response can fuse the appendix to the terminal ileum, the ureter, or even the iliac vessels.
Oh, wow.
Yeah. A master surgeon certainly has the skills for complex adhesiolysis,
Yeah.
but a master surgeon also recognizes when the loss of tactile feedback inherent to laparoscopy, combined with obscured anatomical landmarks, creates an unacceptable risk of visceral or vascular injury.
So the calculated decision.
Exactly. Conversion is a matured, definitive safety protocol. It is never a failure. Failing to convert and causing a catastrophic iatrogenic injury, that is the failure.
That clarifies the protocol immensely, which leads us directly into the geometry of the operating theater. I'm announcing the transition to slide 2. We have an overhead line diagram detailing the position of patient and surgeon.
This diagram is, well, it's entirely about optimizing ergonomics and managing the cognitive load of laparoscopy.
Let's deconstruct the physical choreography shown here. The patient is lying supine. Look at the upper extremities. The right arm is extended straight out on an armboard at a 90-degree angle.
Yes.
However, the left arm is securely tucked alongside the patient's torso.
The asymmetry there dictates the working space for the surgical team. The surgeon marked with an S on the diagram is standing on the patient's left side, roughly at the level of the umbilicus.
Looking across the patient's body.
Right. And the camera assistant, marked CA, is standing immediately cephalad to the surgeon, almost shoulder to shoulder, slightly toward the patient's head.
So the surgeon and assistant are practically sharing the same footprint. It's like a choreographed dance on the left side of the table while looking at a screen on the right.
It really is. And if that left arm were extended, it would act as a physical barrier. It would force the surgeon and the assistant to stand awkwardly away from the table.
Oh, I see. Tucking the arm creates a flush, unimpeded edge.
Exactly. The surgeon needs to be as close to the ports as possible to minimize the fulcrum effect. Laparoscopic instruments pivot at the trocar site. If you are standing far away, a small movement of your hands outside the body translates to a massive uncontrolled sweep of the instrument pip inside the body.
Proximity equals precision.
Right.
And their visual axis is fascinating. The monitor is positioned on the patient's right side, directly in the line of sight of the surgeon. The surgeon and assistant are on the left. Their instruments are entering the abdomen and pointing toward the right iliac fossa, but they are staring straight across the room.
This setup aligns the visual axis with the motor axis. This is the fundamental ergonomic challenge of laparoscopic surgery. Your hands are operating in a 3D space near your waist, but your eyes are focused on a 2D screen at eye level across the room.
That sounds disorienting.
It can be. If the monitor were placed at the head of the bed, the surgeon would have to twist their neck 90 degrees while pushing their hands forward. The neurological disconnect would cause rapid fatigue and spatial disorientation.
So by placing the monitor directly in line with the target pathology, the surgeon's physical movements map intuitively to the visual feedback on the screen.
Exactly. The choreography outside the body dictates the precision inside the body.
Beautifully said. Okay, explicitly announcing the transition to slide 3. We are moving to the port placement slide. We are looking at 3 distinct line diagrams of the anterior abdominal wall.
These diagrams introduce the geometric principle of triangulation. We have 3 distinct trocar sites mapped out here.
Right, let's dissect these. The first diagram details the apical port, a 10-millimeter trocar placed directly at the umbilicus.
Yes. This port houses the insufflation tubing and the 30-degree laparoscope.
Why specifically the umbilicus for that primary 10-millimeter port?
Well, anatomically, the umbilicus is the single thinnest area of the abdominal wall. The skin is directly adherent to the fascia. It's devoid of subcutaneous fat and muscle layers.
Which makes entry easier.
Right. It allows for a rapid, safe entry either via a varus needle for closed insufflation or a Hasson technique for open entry. Furthermore, its central location provides a panoramic vantage point for the camera to survey all 4 quadrants.
So the optical axis is established centrally. Now we need the working channels. The diagrams show the precise trajectory of a 5-millimeter port coming in from the patient's left flank or mid-abdomen,
Right.
and a 12-millimeter port positioned low, suprapubically.
Now, trace the imaginary lines from these 3 ports to the target, the appendix in the right lower quadrant. They form an isosceles triangle.
Oh, I see it. The optical axis comes straight down the middle.
Exactly. The working instruments enter from the left and the right at roughly 60-degree angles to the target. This triangulation ensures that the instruments approach the tissue from different vectors.
It creates a perfect triangle that prevents the surgeon's hands and instruments from crossing or clashing.
Right. If the ports are placed too close together, the shafts of the instruments will constantly clash outside the body. It's a phenomenon known as sword fighting.
Ah, sword fighting. That doesn't sound ideal during surgery.
It's not. And if they're parallel, you lose the ability to apply opposing forces for traction and countertraction.
But wait, looking closely at the 12-millimeter port, why use a large 12-millimeter trocar here for the working hand when standard graspers are only 5 millimeters?
That is foresight engineered into the setup. While you use a 5-millimeter reducer for standard dissection, that specific port will eventually serve as the extraction site.
Oh, so you need the extra width.
Exactly. You need a 12-millimeter diameter to pass an endostapler to transect the base, and subsequently to introduce a 10-millimeter endobag to safely extract the inflamed specimen.
That makes perfect sense. The diagrams also feature these little red crosses scattered across the abdomen. One is high on the right, one low on the right, higher on the left. The legend identifies these as optional sites for 5-millimeter ports. Why might a surgeon need to improvise port placement?
Well, this is where Dr. Selvaraj moves from textbook anatomy to real-world application. Triangulation is the goal, but the exact cutaneous entry points must adapt to the patient's unique internal anatomy.
Right, like if things aren't where they usually are.
Yeah. If the patient has a very high body mass index, a gravid uterus, or dense adhesions from a previous laparotomy, the standard umbilical port might be unsafe or offer a terrible angle.
Or what if the appendix itself is in a weird spot?
Exactly. If the appendix is located high up under the liver, a subhepatic appendix, the entire triangle must be shifted cephalad. The masterclass student must understand that you don't blindly follow the diagram. You identify your internal target first, and then map your port sites externally to recreate that perfect geometric triangle.
Adaptability over rigidity. I love that. Okay, our workspace is established. I am explicitly announcing the transition to slide 4, identification, and then immediately into slide 5, skeletonization of the appendix.
Finding the appendix sounds simple, but in a severe inflammatory state, the cecum and terminal ileum can be plastered together by fibrin and omentum.
The muddy waters again.
Right. The surgeon must identify the anterior tania coli of the cecum and trace it downwards. The tania invariably converge at the base of the appendix. It is a highly reliable anatomical roadmap.
Once identified, we move into the meticulous mechanics of skeletonization. Slide 5 gives us 4 sequential line diagrams plus a real-life clinical photo. Let's create the mental movie here and deconstruct these diagrams.
Okay, let's look at the first line diagram. It shows a blunt grasper coming down. It's gently taking hold of the tip of the appendix and pulling it upwards and laterally.
And you can see the fatty, web-like tissue of the mesoappendix pulled tight underneath it.
That single maneuver achieving correct traction dictates the success of the entire dissection. The mesoappendix contains the appendicular artery and its branches. It is essentially a fold of peritoneum.
Right.
If it is floppy and folded over on itself, you cannot safely identify the vascular structures. By elevating the tip, The surgeon applies axial traction, placing the mesoappendix on a stretch.
Which thins out the tissue.
Exactly. It turns a 3D blob into a 2D plane and makes the vascular anatomy visible against the backlight of the laparoscope.
Here's where it gets really interesting. In the second diagram, a curved instrument like a Maryland dissector is shown pushing through the thinner tissue near the base of the appendix to create a window. The jaws are slightly open, and the artist has drawn a clear hole through the tissue.
The creation of this window is a delicate mechanical process.
Yeah.
The surgeon is seeking the avascular plane, a specific area within the mesoappendix, often near the base, devoid of major blood vessels.
So they push through the safe zone.
Right. They push the closed tips of the Maryland dissector through this thin layer of peritoneum and then gently open the jaws. The mechanical force of the jaws spreading apart separates the tissue along natural planes without cutting.
Isolating the blood supply.
Yes. This isolates the appendicular artery and the thicker vascularized portions of the mesoappendix into a defined pedicle that can be safely managed.
You are segregating the blood supply before you address it. Now, diagrams 3 and 4. These show an instrument, an energy device, or scissors passing through that newly created window.
Right.
And it progressively divides the mesoappendix, moving from the base toward the tip. Visualizing this, the appendix is gradually being freed from its attachments until it stands completely skeletonized and mobile.
The surgeon is likely utilizing ultrasonic shears or an advanced bipolar device here. These tools apply mechanical pressure and thermal energy simultaneously.
So it's sealing and cutting at the same time.
Exactly. The instrument grasps a section of the mesoappendix, denatures the collagen and elastin in the vessel walls to create a seal, and then a blade divides the tissue. This process is repeated incrementally. You create a window, seal, cut, and advance.
And the culmination of this is the fully skeletonized appendix. All the vascular tethers are gone, and it remains attached only at its base to the cecum.
Yes.
But looking at the clinical photograph provided on this slide, I have to say the reality looks far more hostile than the clean line drawings. The appendix shown is this thick, intensely erythematous, pink and red, tubular structure.
It is severely inflamed.
Yeah, it's swollen and curled against the surrounding tissues. The fat of the mesoappendix looks thick and edematous. It highlights the stark reality of the inflamed anatomy.
And that's why this photo is so important. The line diagrams teach you the perfect vectors of traction, but the photograph reminds you of the viscoelastic properties of inflamed tissue.
It doesn't behave like a neat drawing.
Not at all. That edematous appendix is highly friable. If your grasper applies too much crush force, the wall will tear, spilling purulent fluid into the field.
Oh, wow.
And the thickened mesoappendix will not turn into a nice translucent 2D plane when placed on stretch. It will remain bulky. The energy device will require longer compression times to achieve a safe vascular seal.
So the principles remain identical, but the execution must adjust to the physical state of the pathology.
Precisely.
That is a crucial translation from theory to practice. Now that the appendix is skeletonized, we must secure the base before transection. I am explicitly announcing the transition to slide 6, ligation and transection of the appendix.
This slide focuses on the endoloop technique. It's a masterclass in applying extracorporeal knot mechanics to intracorporeal tissue.
We have 3 line diagrams here. In the first diagram, we see the fully skeletonized appendix pointing upwards. A rigid applicator tube is pushing a pre-tied suture loop, the endoloop, down into the abdomen.
Right.
The surgeon is carefully threading the entire length of the skeletonized appendix through this lasso.
The applicator houses a pre-tied sliding knot, commonly a rotor knot, and the challenge here is spatial maneuvering. The surgeon must meticulously thread the entire length of the inflamed, swollen appendix through that loop.
Like threading a needle, but the thread is rigid and the needle is swollen.
Exactly.
Yeah.
If the tip of the appendix snags on the suture, dragging it violently could cause an avulsion of the base.
The second diagram illustrates the deployment. The loop has been navigated down to the exact junction of the appendix base and the cecum. The rigid applicator tube is pressed firmly down against the knot, cinching the loop tightly around the tissue.
Let's analyze the force vectors here. To lock that sliding knot securely, the surgeon must apply intense countertraction.
Pushing and pulling at the same time.
Right. The hand outside the body pulls the tail of the suture forcefully upwards, while simultaneously pushing the rigid knot pusher forcefully downwards. This drives the knot home.
It seals the base.
Yes. The mechanical pressure must be sufficient to crush the mucosa of the appendix and obliterate the lumen entirely. It creates a watertight, airtight seal. If the tension is inadequate, the knot will slip.
And if it's too tight?
If the tension is excessive on highly necrotic tissue, the suture will act like a wire garrote and shear right through the base.
Wow, so the pressure has to be perfect. Now, the climactic visual is the third diagram. Laparoscopic scissors are coming in to cut the appendix above the ligatures. But looking closely, the drawing clearly shows two loops left securely on the stump.
That redundancy is non-negotiable when using suture loops for a luminal closure. The form loop crushes the tissue and creates the primary seal. The second loop is placed immediately proximal to the first, reinforcing the closure.
Double the safety.
Exactly. You are relying entirely on the mechanical friction of that knot to hold back the intraluminal pressure of the cecum. A single loop is a single point of failure. Dr. Selvaraj is explicitly demonstrating that a master surgeon builds in mechanical safety margins.
The real-life photograph on this slide confirms this exact outcome. We see the final result. The pale, tied-off stump of the appendix is resting safely in the abdomen, secured by the distinct, thick knots of the endoloops.
The hemostasis appears complete.
But this isn't the only mechanical solution available, is it? Explicitly announcing the transition to slide 7, we are looking at an alternate method, the stapler.
Where the endoloop relies on circumferential suture tension, the linear stapler relies on uniform linear tissue compression and metallic fixation. It's a completely different approach.
We have a sequence of 4 illustrations here. The first illustration shows the creation of the window revisited. It's that avascular window near the base, identical to the previous method.
Right, so the initial anatomical dissection remains the same.
But then we look at images 2 and 3. It's a marvel to see these heavy jaws of a linear stapler being introduced. The thick metal jaws slide over the tissue, in some cases taking the appendix and mesoappendix together or sequentially.
The biomechanics of the stapler are profound here. When those jaws close, they don't immediately fire.
Wait, really? They just hold it?
Yes, the surgeon must clamp the device and wait. This is because inflamed appendicular tissue is engorged with interstitial edema. The jaws apply immense pressure, slowly forcing that fluid out of the tissue laterally, a process known as tissue creep.
Oh, squeezing the water out?
Right. If you fire the staples immediately into waterlogged tissue, the staples will not form properly, and the tissue will eventually shrink post-operatively as the edema resolves.
Which means the staples would loosen and the stump would leak.
Exactly.
So you alter the physical properties of the tissue before firing. The fourth illustration shows the final staple line. Instead of a tied loop, the diagram shows a flat, cleanly cut, and perfectly sealed line of tiny staples across the tissue.
Device fires 3 staggered rows of staples on either side of the cut line, and a knife blade travels down the center to transect the tissue simultaneously.
It looks incredibly secure. But let me ask you this. If the linear stapler provides a highly secure, triple-row metallic seal and cuts the tissue in one rapid action, why would a surgeon choose the slower, more demanding endoloops? How does inflammation thickness or speed influence that choice?
It is an excellent question that comes down to a matrix of tissue characteristics, anatomical access, and resource management. Let's look at the tissue first.
Okay.
If the base of the appendix is severely indurated, thickened, and rigid due to chronic inflammation, an endoloop might simply slice through the damaged tissue when pulled tight.
The garrote effect you mentioned.
Right. In that scenario, the broad, flat jaws of the stapler distribute the compression forces evenly over a larger surface area, preventing tissue shearing.
So the stapler handles thick tissue better.
Often, yes. But conversely, consider access. The 12mm stapler is a bulky, rigid instrument. It requires a specific angle of approach to lay flat across the base.
And if you don't have that angle?
If the appendix is trapped deep in a narrow male pelvis or adhered tightly to the cecal wall, maneuvering the large anvil of the stapler into position might be physically impossible, or it could be highly traumatic to the surrounding bowel.
So the tool has to fit this space.
Exactly. In that tight, confined space, slipping a flexible endoloop over the tissue might be the only viable mechanical option. A masterclass surgeon must continuously evaluate the physical constraints of the field and select the tool that matches the geometry of the problem.
You cannot force a mechanical solution that doesn't fit the anatomical reality. Speaking of which, I am explicitly announcing the transition to slide 8. Retrocecal appendicitis and retrograde appendicectomy. This is where the anatomy throws a massive plot twist.
This is one of the most clinically significant slides in the deck. The retrocecal position is the most common anatomical variation of the appendix, occurring in roughly 60 to 70% of individuals.
Wow, 60 to 70%. So this is the norm, really. But sometimes the appendix isn't hanging freely, it's hiding behind the cecum.
Right.
The three line drawings here depict a fundamentally different surgical problem. We see the large shaded volume of the cecum, but the body and tip of the appendix are completely hidden. We only see the very base protruding.
The appendix is situated in the retrocecal recess, often densely adhered to the posterior wall of the cecum or even lying retroperitoneally. You have no access to the tip.
So you can't grab it to pull it up.
No, you cannot grasp it to provide that crucial upward traction we discussed on slide 5. The standard technique of skeletonizing from tip to base is physically impossible.
So how do you dismantle a structure when you only have access to its foundation? Looking at images 1 and 2, it shows the surgeon working backwards. It's a retrograde approach.
Exactly.
The red arrows illustrate this. Because the tip is buried, the surgeon isolates the base first. They create a small window immediately adjacent to the cecum, deploy the stapler or endoloops, and divide the base completely.
This is the retrograde approach. You divide the base before you mobilize the body. By completely severing the appendix from the cecum early on, you eliminate the risk of tearing the cecal wall during the subsequent heavy dissection.
And image 3 details the upward pull. The final diagram shows glaspers holding the cut base of the appendix. They are pulling it upward, following the red dotted line arrow, to slowly peel the rest of the buried appendix out of its retrocecal bed.
The surgeon has turned the divided appendix into its own retraction handle.
That's brilliant.
Right. By applying forceful, steady upward traction on the sturdy stump, the hidden mesoappendix and dense adhesions are placed on tension. This exposes the planes. The surgeon then meticulously divides these tethers with an energy device, working their way backward from the base until the buried tip is finally eviscerated.
If we connect this to the bigger picture, it proves how retrograde dissection requires spatial mastery and adaptability. The surgeon must be ready to reverse their standard workflow.
And you must maintain absolute hemostasis during this retrograde peeling. Because you're working behind the cecum, any bleeding can quickly pool and obscure your field. The retrograde dissection demands immense patience.
I can imagine. Once the tip is free, the resection is complete. But the pathological cascade doesn't end when the instruments are withdrawn. Explicitly announcing the transition to slide 9, complications.
This slide is vital for postoperative care.
Yeah, revisiting the risks post-op, this slide lists the exact same data points as the informed consent slide. Post-op adhesions less than 1%, intra-abdominal abscess less than 8%, fecal fistula less than 2%.
The repetition here is deeply intentional, but the context is shifted entirely. On slide 1, these numbers were theoretical possibilities discussed in a preoperative setting to establish informed consent.
Right.
On slide 9, the patient is in the post-anesthesia care unit. These percentages are no longer abstract. They are a direct reflection of the physical actions taken during the surgery.
So this slide serves as a post-operative vigilance checklist for the surgeon. The masterclass student must keep these specific percentages in mind during post-op rounds. Let's focus intensely on that less than 8% risk of an intra-abdominal abscess. What does that vigilance actually look like?
Well, the masterclass surgeon is mentally reviewing the mechanics of the specific operation they just performed. Was the appendix perforated upon entry? Did purulent fluid spill when applying traction to the friable tissue?
Did I clean it up enough?
Exactly. Did I achieve a comprehensive peritoneal lavage, suctioning the pelvis and the right pericolic gutter until the effluent was crystal clear? If the answer suggests high contamination, that 8% risk escalates rapidly.
So what are the physical signs they're watching for on the floor?
Clinically, the surgeon is hypervigilant for a swinging pyrexia, a spiking fever on postoperative day 4 or 5, or a persistent tachycardia out of proportion to pain, or a prolonged paralytic ileus where the bowel refuses to wake up.
Those are the markers that the muddy waters have returned as a localized fluid collection.
Yes. And what about the less than 2% risk of a fecal fistula? That is a direct audit of the mechanical integrity of the stump closure.
Did the stapler misfire on thickened tissue? Did an endoloop slip?
Exactly. A fecal fistula means the cecal pressure has blown out the stump and intestinal contents are leaking freely into the peritoneal cavity. It presents as severe localized peritonitis or feculent output from a surgical drain.
It's a catastrophic mechanical failure.
It is. The surgeon must own these numbers postoperatively.
Which brings us to the ultimate synthesis of safety protocols. I am explicitly announcing the transition to our final slide, slide 10, clinical pitfalls.
Dr. Selvaraj has isolated 3 absolute pillars of procedural discipline here.
Let's break down the first pillar. The text reads, Failing to achieve the critical view of safety viewing appendix base, cecum and ileocecal junction, is a leading cause of inadvertent cecal injury. Why is identifying this specific triad of landmarks non-negotiable before making any cuts?
This is the most vital conceptual takeaway of the entire masterclass. The phrase critical view of safety originated in laparoscopic cholecystectomy, but it is equally mandatory here. As we discussed, severe inflammation obscures anatomical boundaries.
Right, the terminal ileum and the fallopian tube can look just like an engorged appendix.
Exactly. They can all appear as identical, engorged, red tubular structures coated in fibrin. If a surgeon grabs the terminal ileum, misidentifies it as a long appendix, and fires a stapler across it, the resulting bowel resection, or worse, a mistransection leading to overwhelming sepsis, is an indefensible error.
Oh, that's terrifying. So the critical view is a mandated systemic pause.
Yes. It demands definitive visual confirmation of 3 converging anatomical landmarks before any irreversible action is taken. You must visualize the broad sacculated wall of the cecum. You must visualize the exact origin of the appendicular base arising from that cecum. And crucially, you must trace the anatomy to identify the ileocecal junction.
The distinct point where the small intestine enters the large intestine.
Right. If you see the ileum entering the cecum, and you see the base of your target structure arising from a different point on that same cecum, you have mathematically eliminated the possibility that you are holding the terminal ileum.
It replaces assumptions with absolute structural relationships.
If dense adhesions prevent you from achieving this triad of landmarks, you do not deploy the stapler. You continue sharp dissection, or you convert to open surgery.
The second pitfall brings up endoloop failure. The text warns about inadequately placed endoloops around the base and mesoappendix, leading to slipped loops, incomplete hemostasis, and post-op bleeding.
This underscores the physics of the rotor knot we detailed back on slide 6.
Right, tying it back to the knot pusher.
Exactly. It's not just about placing the loop. It's about the vector and force of the knot pusher, ensuring adequate tissue compression without causing ischemic necrosis. The redundancy of double loops is the direct mechanical safeguard to this pitfall.
And the final pitfall is the endobag rule. It says, extracting the appendix through the port site without an endobag risks wound infection, port site abscess, and potential tumor seeding.
We touched on the 12mm port being designed for extraction earlier, but we really need to analyze the physics of dragging the specimen out.
Right, I mean, you're dragging an inflamed, infected organ directly through the abdominal wall. That ruins the sterile field.
Consider the biological state of the resected appendix. It is a concentrated cylinder of aerobic and anaerobic bacteria. The trocar site is a fresh, full-thickness surgical incision through the sterile planes of the fascia, muscle, and subcutaneous fat.
So pulling it through unprotected.
If you pull that highly contaminated tissue directly through the trocar, or worse, directly through the raw incision if you remove the trocar, you are forcefully inoculating those sterile fascial planes with billions of bacteria.
You are injecting a severe wound infection directly into the abdominal wall.
Yes. A port site abscess is deeply morbid. It requires complex packing and prolonged recovery. Furthermore, the pitfall mentions tumor seeding.
Which is rare, right?
Rare, yes. But appendiceal neoplasms like carcinoid tumors or mucinous adenocarcinomas often present as acute appendicitis. If you drag an unrecognized malignant tumor through the narrow bottleneck of the incision, these shear forces can scrape viable cancer cells off the organ and implant them directly into the abdominal wall musculature.
Oh, man. Transforming a curable lesion into an abdominal wall metastasis.
Exactly. The endobag is the absolute physical barrier against this cascade. It acts as a necessary quarantine pod.
A sterile, impermeable polyurethane pouch is introduced, unfurled within the pneumatic workspace, and the specimen is placed inside. The mouth of the bag is cinched tight via a durable drawstring.
And then the entire sealed pod containing the contaminated organ is withdrawn.
The infected or malignant tissue never makes contact with the sterile surgical field, the trocar, or the patient's fascial layers. It's a beautifully simple mechanical solution.
It truly is.
Well, from establishing the pneumatic workspace and calculating the geometric triangulation of the ports, to the meticulous physics of skeletonization and mechanical closure, right down to the rigid quarantine protocols of extraction, we have mapped every phase of this procedure. I'm hoping the mental movie of those line diagrams and clinical realities is vividly playing in your mind.
If the masterclass student has deeply internalized the physical mechanics and structural rationale underlying every slide in Dr. Selvaraj's presentation, Well, they possess the cognitive framework necessary for operative excellence.
Absolutely. And as we conclude this deep dive, I want to leave you with one final structural thought. Achieving excellence in surgery, particularly in the unpredictable environment of the acute abdomen, as Dr. Selvaraj outlines, isn't just about how well you handle the instruments. It is fundamentally about unwavering visual and mechanical discipline. When you are staring at a difficult, densely adhered retrosical appendix, or struggling through edematous tissue to get the critical view of safety, remember that the true mark of a master surgeon is the profound discipline to pause, reorient your visual axis, and never cut what you cannot definitively identify. Thank you for joining us for the Specialized Operative Deep Dive. Keep running that mental movie, and we will see you next time.